evening. Good evening, all. Welcome. Thank you so much for joining us this evening. My name is Scott Kopetz, professor of GI Medical Oncology, and I'll introduce my co-leads here in a minute. But welcome you to the peer review live. This is the Therapeutic Progress and Impact in Colorectal Cancer Expert Guidance. So we'll be talking about emerging evidence on immunotherapy, molecular precision-based approaches, and CRC treatment. And if there's one thing that you know about GI oncology is that we love our acronyms. So this is the IMPACT, in case you're wondering. So delighted to have you. This is also co-sponsors, we'll talk about in a little bit, by the Colorectal Cancer Alliance. So thank you. So delighted to be joined by Dr. Kathy Eng and Dr. Marwan Fakih from Vanderbilt and City of Hope, respectively. And thank you to our supporters, as you can see there on the slide, BMS, Exelixis, J&J, and Taiho, for providing the unrestricted educational grants for this symposium. Now, hopefully you got the message. There was a QR code and a few voiceovers, and I think you got on the way in that there is a pre-event survey. So I'll show the QR code here in a minute if you haven't done that already. That's also the place to do the Q&A. We will be polling you during the presentations. And of course, we'll have a question and answering session, so please submit your questions. Those of you here in person, we can do questions by microphone, but feel free to also submit them through the QR code. We do have a large online audience as well who will be participating too. Okay, with that, here's the QR code as promised. We all love a little incentive, and so reminder, there is apparently a gift card, so please make sure to QR code here to do your surveys, and that's also questions as well. Okay, so just a reminder, there are some that this material, it can be downloaded, so I think helpful for any teaching education ones. So this QR code can also get you the slides and the practice aids either now or after the session. And there's an email down there as well. Okay, with that, what are we going to learn today? So hopefully we'll leave you with the recognition that doing the right comprehensive molecular profile in patients with metastatic colorectal cancer is critical to guide patient selection and treatment selection. That we'll be hearing about the expanding role of immuno-oncology and targeted therapies in colorectal cancer. So really acknowledging that our management is getting more complex, not necessarily easier, but we'll talk through some of the strategies there. And of course, recognizing that this is a team-based therapy to optimize management when we're treating colorectal cancer patients. All right, a little bit of background here to start. We'll talk about some of the backgrounds on precision-guided care. So one of the shortcomings in the field, and I think something we discuss a lot as a group, and I think are making progress on, is really doing optimal biomarker testing. And one of the take-homes we hope to leave you with is the idea to make sure that we are doing testing appropriately and getting that done at the right time. Now, we all recognize the barriers of getting this information back in time for our first-line treatment decisions, and ensuring that we have the right treatment for the right patients. But as you'll hear, really the advent of molecular targeted therapies with improved outcomes and immunotherapy for MSI-high really necessitate knowing a lot of this information before we start. The targets that we'll be touching on, just to highlight the things that are relevant, of course, are MSI, in a few percent of patients, but an important few percent to know about. We have our ERB2 or HER2 amplification and overexpression, MET amplification, uncommon, but MET is an important driver. NTRK fusions, 1% I think is a little generous. Probably I'd put a decimal point in front of that 1%, but nevertheless, very, very meaningful for patients when you do see it. And certainly thinking about how we're utilizing RAS targeting and targeting our wild type patients as well. And then we'll talk about BRAF as a population as well. So here's, if we think about these subgroups with our Venn diagrams and the relative sizes of these here. So acknowledging that certainly RAS mutations are dominant, but within those really actionable clustered groups here in the middle, and the no biomarker, the RAS-RAF wild type population relevant as well. This is just a nice figure showing that, as we get better biomarkers and utilize them, that we get not only higher response rate, but prolonged median progression-free survival here as well. So there's as we'll go through in more detail and in each of these individually, there's real rationale for getting this molecular data back. Now, what sort of testing do we do? So, PCR for mismatch repair. It's been around for many years, still can be utilized, and has good sensitivity as long as you have enough tumor that's present and you need a normal germline control. IHC used for both mismatch repair as well as HER2 expression as well. And then NGS we'll talk about for comprehensive genomic testing, and this is a lot of what we're doing, I think, in the real world now, but acknowledging some of the downsides of that, but also that a lot of these now can be utilized and are giving back more information about the mismatch repair and MSI status as well. Now, tissue is not the only one. I think, colorectal cancer, we're now, as a field, getting a lot of comfort with the idea of how do we utilize ctDNA for profiling patients, especially patients that are newly diagnosed, right? Patients that haven't been on treatment yet, where we know that the sensitivity of these assays are really good for detecting the molecular subtypes. Where we're talking about liquid biopsies, traditionally right now we're talking about circulating tumor DNA, but this is a figure just reminding us that there's a lot of other avenues including methylation testing, circulating tumor cells, and others that can be part of the broader category of liquid biopsies, although not quite utilized yet. All right, before we dive into the first topic here, just want to remind everyone that colorectal cancer really is a community effort, and that an important part of that community is the patient advocates and making sure we have the information that we can get to our patients. And we're thankful for the Colorectal Cancer Alliance, who's really spearheading a lot of this work. This is a number of QR codes here that you can download this. If your smartphones must be better than mine, because I'm not sure how I'd get one of those QR codes to fire out of the 8 on there. But regardless, a lot of great work going on. I think you may have seen the video here a little while ago about Project Cure CRC, so major initiative ongoing to fund research, and there's some really innovative clinical trials that are launching that was released today by press release as well. So check out some of that information. And then patient resources there as well. All right, so here's our case that we're going to utilize for our first section. So this is Thomas, 57-year-old patient, newly diagnosed cecal colorectal cancer with liver metastases. You can see a little mild anemia, platelets, kidney function, bilirubin look good, performance status is good there as well. And these are the questions that we're going to be circling back to here after some background, and really talking also about, what is the best methodology for testing. So our first of the three sections will be looking at how do we personalize these interventions around immunotherapy. So really thinking about what is how do we identify patients with MSI high, and then what do we do with those patients. So what are some of the data that we have? And we'll talk predominantly about frontline, which is where a lot of the immunotherapy data has been moving. Now, if we think about our NCCN guidelines here, so this is our MSI high patient population. And on the left, you can see in classic NCCN style, right, where NCCN loves to give you all the options available. So here's your long laundry list of potential agents that could be utilized in these settings. Patients have no prior immunotherapy. You can see a lot of PD-1, PD-L1 options, as well as a PD-1, CTLA-4 there at the bottom that we'll talk about. Interestingly, although we won't have a lot of data to share today, but interestingly, they do have a note there that patients who've received prior immunotherapy may be a candidate for Nivo/Ipi. This is an area where there's potential, at least, to salvage in patients who did not respond to a PD-1 there as well. Okay, so what's behind all this? Well, the first question is, who are the MSI high? And I think, we're familiar as a field with how to test patients in general, but I think one of the key messages that sometimes come up is this idea of misdiagnosis of MSI high. And when you actually dive into some of these studies, this is now looking at some of the checkmate studies that have been reported, what was seen is that MSI high can be misdiagnosed, and at least in this study, it was 14% of patients, meaning that the local test that was done said that there was MSI high, and when they sent the tissue in for central confirmation, 14% of those could not be centrally confirmed. And you can see that for most of those, it was the test could be done, but the test actually could not confirm, and by two different methodologies showed MSS, or proficient mismatch repair. So this really speaks to the idea of the potential for there being a false, a false positive or false MSI high call. There's also the converse about how often, it is probably less than this, but how often are MSI high tumors missed by testing where we call them MSS, even though they may be MSI high. So there's a lot of efforts to really say, how can we really optimize this? Because as we'll show you, MSI is such a critical biomarker to get right? That this is absolutely something that we don't want to send patients down the wrong treatment path. And so while we do know that IHC can be a really important screening, that there are indeed false positives that can come up due to some of the polymorphisms in the targets by immunohistochemistry that can come up. Sometimes we'll think about that in a number of different settings, but PMS2, for example, is one that we'll commonly see false positives or false losses. So the recommendation really is to think about ensuring that you have a second methodology, and that could be PCR, but it could also be NGS, looking for that hypermutated pattern to really kind of confirm and make sure that you're IHC. So the recommendations now are really to do both, get both of these tested to really avoid some of these misdiagnoses. All right. Well, I don't know about you. I wish we had tests like this back in college where the professor would give you the answer and immediately ask you the test question, but here's exactly what it is. So what would you order for a patient newly diagnosed with metastatic colorectal cancer? NGS alone, IHC for mismatch repair only, MSI status by either PCR or NGS alone, so just be doing one of them, or would you be doing both the mismatch repair by IHC and a second orthogonal methodology? Or 5 is would not perform testing unless disease progression occurs, or I'm not sure. So please go ahead and scan to answer this. And a reminder, once you do scan, you don't need to scan it again. So if you just keep that tab open, the next questions that come up will pop up. Okay, numbers are coming in there. Yeah, absolutely. So predominant population there, 70% of patients really saying that, of the respondents are saying that patients should be tested by both IHC and a second methodology there as well. Okay, wonderful. All right, so what's some of the data? So I'll take you through in a kind of a rapid fashion here how we're, got to 2026 with our data for MSI high. So one of the first ones, again, focusing on our randomized studies, is the Pembro versus chemotherapy. This was the Keynote 177 study. And this is now several years old data, but with mature update, and really demonstrating that impressive difference in progression-free survival. There's as we'll come back to, a little comment about perhaps a little bit of an early progression on the Pembro, and then the arms cross, and Pembro clearly is the best performing one. But you can see, as approaching up to 5 years, that in this case, by the 3-year mark, 42% of patients were free of progression, which is very impressive. And the PFS2 is the next line therapy then as well. So a number of patients on chemotherapy were able to cross over. The overall, because of that crossover, the overall survival there, you can see numerically heading the right direction. It was based on their alpha that they'd allocated to it. They did miss the overall survival, but again, with the crossover, the sense is that this is really, the PFS is telling the story of the benefit there. And you can see the response rate, including 13% at least radiographic CR rate with the pembrolizumab. When you look at that by here numerically, as we talked about, there was a proportion of patients that had initial progression. So 29% of patients in the Pembro arm at first scan had progression compared to 12% on the chemotherapy. And you can see the PFS in key subgroups really suggesting the benefit is seen in all the subgroups, and there's no actually statistically significant interaction that's seen there. Now, because of that early progression, one of the questions in the field was, well, what if we actually combine chemotherapy and a PD-L1 in this case? So this is the commit study, or SWOG 1610, atezolizumab, bevacizumab, and chemotherapy versus atezo alone. So after the Keynote study came out, the FOLFOX bevacizumab arm was discontinued. And you can see, again, first-line patients, treatment naive, 211 patients enrolled. And what was seen was indeed no early crossover, right? So you remember that crossover with the PD-1 there, but the chemotherapy plus the PD-L1 showing a benefit. And you can see that the addition of chemotherapy had a statistically significant improvement on top of the atezolizumab. And so this is also an option that is now on guidelines as a result of that. And you can see the response rates, 50% response rate versus 27 for the atezo alone. Now this is, we're mixing and matching PD-1, PD-L1 agents, but nevertheless, the contribution of components with the chemotherapy is noted. Now, we knew going into this, based on some second-line data, that the use of a PD-1 plus CTLA-4 can produce longer-term benefit, a better plateau here. And this is what we call cohort 1 and cohort 2 in the second line and beyond. And what was seen here is response rates of 65%, with the nivo-ipi versus nivo alone of 39%. And when we looked at first-line patients with nivo-ipi, that response rate then went up to 71%. So these, again, unrandomized data, but really was data suggesting that the addition of ipi provided some numeric benefit. And that was the rationale behind the Checkmate 8HW study. So this was now looking at a investigator's choice chemotherapy versus nivo plus ipi. Now, importantly, as they say, this is not your parents' ipi, right? So this is 1 mg per kg ipi dose there, Q3 week for 4 doses. So we're going to look at curves that are spanning out over years of outcomes for these patients. But what we're talking about is kind of a difference of what you do in that first 12 weeks of the patient's management with the immunotherapy. So the first, of course, demonstrating that PD-1 CTLA-4 was substantially better than the chemotherapy arm, and so you can see wide separation here in these curves, but also a very reasonable plateau, right? So the idea, even out at 24 months, 72% of patients still on therapy with the nivo-ipi versus 14% for the chemotherapy alone. Now, the question that we're all most interested in was, what about the addition of ipi compared with the nivo alone? So here, what you can see is nivo-ipi versus nivo, and looking at the hazard ratio of 0.62, favoring the combination, and a p-value of 0.003. 0.0003. I would encourage you, when we're looking at these immunotherapy curves, really to start to look at what that plateau is. And that's because we're increasingly recognizing this plateau may be defining a real cure rate for these patients, right? Because when the rate of progression after patients have been on here beyond 2 years is very low. And so when we're seeing these differences at 36-month rates, at least my interpretation is we're really getting a look into what's the rate of cure of these patients. So here, looking at 68% versus 51% difference in that 36-month rate. So a real, I would argue, kind of meaningful difference, as well as statistically significant difference in these curves. So PFS 2 here as well. So kind of thinking about, well, what is the PFS, not of 1 line, but 2 lines of therapy, and you can see that was maintained there as well as what the patients went on to receive. Now, the impressive thing, and I think we all appreciate that as treating patients, is that patients' performance status and global health status really substantially improves pretty quickly. So usually within about 2 months, 3 months or so, they're kind of back at their pre-diagnosis baseline in terms of their quality of life. And so these are seen with regard to the actual treatment in this, but these are kind of meaningful measures of patient quality. Now, what about the treatment-related adverse events here? So the serious treatment-related adverse events, you can see and the rates leading to discontinuation, you can see the numbers. What we see is a higher rate of kind of low-grade toxicities with that. So you can see the grade 3-4 rates are really not substantially different between the nivo versus nivo-ipi. There's a few, like a slightly higher rate of grade 3-4 rash or adrenal insufficiency, for example. But the distinctions here between the safety profile with these average side effects are modest. Okay, so here's our 57-year-old patient with MSI-high deficient mismatch repair. So he had the dual testing that you guys recommended done, and both confirmed MSI-high. And he wants to be aggressive. Performance status is good. No comorbidities, no autoimmune disease that he has. So based on that evidence that I showed you, what would you recommend? So we have Nivo monotherapy, Pembro monotherapy, Nivo plus IPI, chemo, plus or minus a targeted therapy, or I'm not sure. So please go ahead and scan and answer. Okay, there we go. So you can see the numbers there. About 75% of providers saying the patient should get Nivo IPI here in this case, and certainly some that I think some certainly acknowledging we need, let me chew on it a little bit. I'm not sure, but certainly I think the data suggests that in the right patient like this who wants to be aggressive, that really could be, or there is statistically significant and clinically meaningful improvements with the Nivo IPI. Okay, what are the immune-related toxicities? So we talked about the all-comer toxicities, but what about the other, the kind of immune-related ones? This is a nice figure that kind of helps highlight some of those. What I would encourage you to look at is the Nivo IPI plus and the Nivo or the Pembro numbers, so that looking at, yes, there's a higher rate of increased ALT, some higher rates of colitis, hypothyroidism, but hypothyroidism seems to be pretty similar across the PD-1 versus PD-1 CTLA-4 there. So there are some increased risks to be aware of and certainly communicate with the patients here, but this is a much better profile with that lower dose, that 1 mg per kg IPI than we see with the older regimens. Now, what about the timing of this? So this is kind of a classic figure from several years ago that really reiterates that that these side effects can come on at any point, and especially things like endocrinopathies that can happen at any point. Some of them you'll start to see those toxicity rates drop some. But the real message that we want to leave with patients, and I think with the providers, is that this can really occur, a lot of these adverse events can occur at any point, even months after starting treatment. So it is important to make sure we're educating patients about side effects to be aware of, and just and notification there as well. So here's some general principles of IRAE grading and how do you manage that. In general, grade 1, nothing you need to do. Grade 2, you can hold for the grade 2s and then just resume when the side effects start to disappear. Rarely do you need to use steroids, but occasionally you can for those mild to moderate grade 2 symptoms. When we get to grade 3 toxicities, you're really talking about holding the checkpoint inhibitor. Here's where kind of starting some steroids is certainly warranted. And then if a patient do not improve within 48 to 72 hours of the corticosteroids, that's when infliximab or the biologics may be used for some of the toxicities. And then usually requires a bit of a longer tapering. But when the symptoms or the laboratory values revert back to grade 1 or disappear, and most of the time you're able to re-challenge with some in immunotherapy. You just have to acknowledge that sometimes it will come back, but not always. But I think that's an important point, is that for these grade 3s, a re-challenge is certainly warranted. Grade 4s, that's usually when we start to say the risk of grade 4s are too high. Now, the exception there are endocrinopathies that you can replace, such as hypothyroid, that you can replace and continue on. Okay, our last question for this section. So here is our 57-year-old again, who's getting Nivo IPI. How should we educate him on the potential treatment-related adverse events? So one is explain that these develop early and they'll resolve on their own. explain that this can involve any organ system during or after treatment at any time point, and make sure to communicate about possible AEs with the healthcare team. Could be, number 3, explain you could get a rash or diarrhea, but you can use over-the-counter medications, and talk to you at the next appointment in a few weeks if the symptoms are gone or not gone. Or that, that while they're rare, they can be life-threatening, and they generally require permanent treatment discontinuation for any grade adverse event. Or I'm not sure. Okay, right, so 73% there. I agree, this is the best response. Remember that while we draw graphs about when things can come and go, but they can really occur at any point, and communication is really clear there as well. Okay, so a final point here, just because this is on the NCCN guidelines of what do you do after a PD-1 progressor? Do you do a PD-1 CTLA-4? So just acknowledging here that there's not a ton of data, but the NCCN, I think, is really reflecting the fact that these are patients that we can potentially cure. And there's at least case reports and series that suggest that going in with a PD-1 CTLA-4 after may indeed be synergistic. And the rationale here is that really CTLA-4 is priming effector T cells. So if there's not a presence in an effector T cell yet, PD-1 may not work. But if you give a CTLA-4, prime the T cells, generate a T cell response, and then and combine that with the PD-1, that there may be benefit. There's also data about how CTLA-4 may bring down the Tregs, which is another key modulator of Treg biology complex. Not all CTLA-4s are the same in that regard. But together, this is kind of the rationale of why the NCCN is providing that option. Okay, so discussion for our panel here. So here's our patient, and any comments on the molecular testing that was done, kind of potential treatment options. We've kind of walked through this case a little bit, but a few questions here that open it up. Anything you would do differently, other considerations that we didn't discuss in that, and then what factors inform your decision to use dual checkpoint blockade versus monotherapy? Kathy, you want to start?
I mean, sorry. I mean, this gentleman, his performance status appears to be very good. His laboratory tests are within normal limits. It seems like he's a very good candidate for combined immunotherapy. So currently, I don't have any concerns based upon the information that was provided to us. He had IHC completed, if I'm correct, as well as the NGS as well.
Yeah. So, yeah, go ahead, Marlon.
No, I mean, I agree. I personally do get NGS on all these patients, not just IHC and PCR, and personally, that's my preference, is really just NGS. I think it's nice to have IHC on top, but it gives you really comfort that it is also a hypermutated tumor, right? And because you can have heterogeneity in the tumor by IHC, and I think sometimes you'll be surprised and you'll find a lower TMB. Not that it changes your management, but that's a bigger incentive for me. If it's a TMB of 23 or 18 or 19, which is still high, to certainly even push further for a doublet. Certainly, I would agree with Nivo-Ipi here.
Yeah, so an interesting nuance there, this idea to say, are there a subset of patients that just do not have enough, a high enough mutation burden that maybe they need that little extra push for the immune system to recognize every mutation that's there as well. So I think these are part of the things, and while these treatments have been around now for many years, there's still so many questions like that we don't, that we still need further data on, but I think a really kind of elegant way to think about that. One final question is subcutaneous
Yeah.
PD-1s, right? After that first 3 months of Nivo/Ipi, any reason or is your practice to switch to subcutaneous?
I'm actually doing this in a patient starting with her next cycle. She's going to maintenance, and I'm going to do sub-Q.
Okay.
She's going to be my first.
All right. I've yet to do it, so yeah.
Yeah, we actually have an institutional policy now that all patients can be switched, so
Great.
everybody does.
Yeah.
Sounds great. Okay. Good. And patients, the experience with the patients, Marwan, you've had?
So far, so good. It's less time for them in and out, so I think nobody has asked to go back on infusion so far.
That's good. That's the key. Happy patients, for sure. So, all right. With that, let me turn it over to Dr. Eng next. Yeah.
Thanks so much, Scott. So I'm going to be talking about other targeted therapies. Scott's given a great overview of what's available specifically regarding the IO space. Marwan and I are going to be focusing on some of the other pathways. So my very first focus will be targeting EGFR and MET. I think many of you are very familiar with the fact that we now know that obviously the benefits in treatment-naive patients specifically for EGFR therapy largely resides in left-sided tumors, and it's really not necessarily recommended in right-sided tumors based upon prior studies, including CLA-GB 80405. And so anatomy and geographic location of the primary tumor is important when a patient is originally diagnosed. We also had the phase 3 paradigm trial, which was a very important trial that looked at both left and right-sided tumors originally, but really decided to randomize study a head-to-head comparison of anti-VEGF therapy or anti-vascular endothelial growth factor therapy versus anti-EGFR therapy for patients that were RAS wild type. And then, as you know, they amended the trial to really focus specifically on the left-sided patient population just because of other data that had come out. And as mentioned earlier, 80405 had noted for right-sided tumors, newly diagnosed patients, they shouldn't receive anti-EGFR therapy up front. So Paradigm really established a new principle to focus on left-sided tumors and look at the benefit from anti-EGFR therapy in combination with oxaliplatin-based treatment. And you'll note that the median survival was almost 38 months versus kind of standard FOLFOX plus bevacizumab of 34.3 months. With a hazard ratio of 0.82 and a p-value of 0.03. This has largely been adopted, as many of you are aware, specifically with our European colleagues. We offer it to our patients here in the States, but I have to be honest, not always will patients agree to it just because we now know, obviously, anti-EGFR therapy does have some toxicities regarding skin toxicities. But amivantamab is interesting. It's a new drug that we have available in clinical trial development. It's already approved in lung carcinoma. It's a bispecific antibody that's unique versus what we have with our plain anti-EGFR therapies. It inhibits not only EGFR, but MET, and its immune cell directing activity. Origami 1 was just recently published. This was a small study. It was a phase 1 with a phase 2 dose expansion. It involved 94 patients. It had 3 arms. The first arm was treatment naive to anti-EGFR therapy for left-sided tumors. Cohort B was left-sided tumors, but you were allowed to have prior anti-EGFR therapy. And cohort C was right-sided tumors. So these patients were allowed to receive treatment. They had right-sided tumors, and they may or may have not had prior anti-EGFR therapy. Patients basically had to have confirmed unresectable disease, ECOG PS of 0 to 1, and they may have received greater than 2, but not more than 3 prior lines of therapy. So which of the following accurately describes patients who are eligible to enroll in the phase? It's not a phase 3. I'm sorry, we thought we removed that. The phase 1/2 Origami 1 trial. Once again, these were either evaluating the efficacy of amivantamab. So please scan to answer. So the options are patients with MSI high, deficient mismatch repair who have not yet received first-line immunotherapy, patients with RAS wild type after progression on standard therapy and anti-VEGF therapy, patients with HER2 amplified are not eligible for trastuzumab-based therapy, and patients with KRAS G12C mutated disease progressing after sotorasib and panitumumab, or I'm not sure. So this, once again, is not a phase 3 trial. This is mislabeled. Please scan to answer. We're just going to give you, it's mostly to be informative. You're probably not going to know the answer because, once again, it's a small phase 1, phase 2 study. and I don't expect you to. Very good. So patients basically, once again, it's not a phase 3, so apologies for that, that title up top. But patients that were eligible were patients with RAS wild type after progression on standard therapy and anti-VEGF therapy. So you guys listened really well, quite impressive. And the 25% they're not sure, not an issue. Don't worry, I may have been speaking too fast. So. Okay, so the results from Origami 1 were published just recently in JCO. And remember, there were cohorts A, B, and C. So on the top is basically cohort A was left-sided tumors. They had never received prior EGFR therapy. It was a small number of patients, 17 patients, but the response rate was 29%, and the PFS was about 6 months. And the middle is left-sided tumors with prior anti-EGFR therapy, larger number of patients, 54 patients. The PFS was about 5 months, and the response rate was about 19%. And then for the right-sided tumors, which we normally would always are a little hesitant with anti-EGFR therapy, as you can see, there's still benefit. The response rate was 22%, and the PFS, though, was shorter at 4 months. So there is activity, at least based upon this phase 1, phase 2 trial that was conducted. Now, at this year's ASCO, there's further analysis of the Origami 1 based upon some correlates that were completed. They looked at CMS, consensus molecular subtypes, and they noted CMS2 and CMS4, so conical and mesenchymal, comprise 95% of the tumors. Historically, CMS2 is about 40% of our patient population. CMS4 is about 23%, and CMS2 usually has a better prognosis. Clinical outcomes were comparable based upon median PFS and median OS, and then it basically remained consistent across sidedness. There was just some interesting data. Once again, we really just want you to highlight what's being shown here at this year's ASCO. It's going to be a poster presentation, abstract 3548, and they noted that amivantamab generally decreased amphiregulin, epiregulin expression and increased hepatocyte growth factor expression, which is, which is not unexpected for CMS2. So these are the current ongoing trials that are available to patients. So Origami 2 is building upon the original concept of Origami 1. Once again, it's for left-sided tumors, all RAS wild type. It's going to involve a total of 1,000 patients, and the control arm is FOLFOX or FOLFIRI plus cetuximab versus the investigational arm with amivantamab. And Origami 3 is in the second-line setting, so that's FOLFIRI. So we presume most patients have received FOLFOX. So it's FOLFIRI with bevacizumab or cetuximab. It's going to be about 700 patients versus the investigational arm of amivantamab plus FOLFIRI. And these are both international trials. So I was going to talk to you about my real-life case. This is a 48-year-old gentleman with a history of RAS wild-type tumor. MSI stable, ascending colon carcinoma, had a right hemicolectomy. 3 of 12 lymph nodes were positive. Unfortunately, as you can see on the top picture of the CT scan, you can see bilateral lung metastasis. And in the bottom picture is just his CT scan, which demonstrates multiple liver metastasis. He previously received FOLFOX plus bevacizumab, held the oxaliplatin due to neuropathy, had continued the maintenance therapy, and had done very well, but had persistent grade 2 neuropathy, and unfortunately has now progressed. His ECOG performance status is 0. So part of the case discussion is how would you proceed with sequencing of this patient? Would you consider amivantamab via clinical trial? And what patient-specific characteristics would you take into account for clinical trial eligibility? So if I'm correct, we're going to talk about that later, or not?
We can discuss it now.
Okay. So what are your thoughts on this one, Scott?
Yeah, so you know, the key as you're thinking about this RAS wild type patient is, you know, this instinct to think about EGFR, but this is an ascending colon, right? Mm-hmm. So kind of a right-sided, and we know that, you know, right-sided do not particularly respond there. Now, the intriguing
second line setting.
Correct, and so there's there is perspectives about whether EGFR inhibitors don't work for right-sided in every line of therapy, or where do we have the strongest data? So I certainly acknowledge that. But the intriguing data from AMI was that when looking at an EGFR MET bispecific, there at least was some activity that was
22%.
seen on the right side there. So certainly an interesting area to explore, and so it would be something that I would be intrigued to think about clinical trial for this patient.
Yeah, no, I agree. I mean, I think we also know response rates are higher in the second line with anti-EGFR, although it doesn't carry with PFS, and it's always been a controversial topic. But given the activity in right-sided tumors with amivantamab, it's certainly worth a discussion with the patient about enrollment on the study and weighing in the side effects of the combination therapy in this case versus other trials for that matter.
Thank you so much. Now, next topic is we're going to go on your favorite topic, BRAF, V600E, which is hilarious because I'm sitting next to Scott. So just friendly reminder, having a BRAF V600E mutation is less than 10% of our patient population, roughly 9%. It's always been a relatively poor prognostic indicator for our patient population. And we also are very focused on the fact that there are those patients that are MSI high, so due to hypermethylation with the BRAF V600E mutation. These two curves basically are planned analysis that were conducted as part of Keynote 177, which noted even if you were a hypermethylator and had the mutation, you still benefited from pembrolizumab versus chemotherapy alone. And then in Checkmate 8HW, once again, a pre-planned analysis of the combination nivo-ipi versus chemotherapy, noting specifically that they still benefited, even as a hypermethylator, with the use of combined immunotherapy in this setting. Now, for the patients that are non-MSI high, for those who are MSI stable with the BRAF V600E mutation, here, many of you may recall, we presented this data with Scott and other investigators leading this effort. And in full disclosure, I was one of the investigators as well, looking at moving the combination of encorafenib, which is a BRAF inhibitor, plus cetuximab, which was already approved in the previously treated setting, to the frontline setting in combination with oxaliplatin-based therapy. So can we make a bigger difference from moving it from the refractory setting in combination with chemotherapy in newly diagnosed patients? And what you probably noted, because it did result in FDA approval in February of this year, was that the median survival for oxaliplatin-based treatment in combination with encorafenib and cetuximab resulted in a surprisingly very positive median survival of 30.3 months. When you compared it to standard of care chemotherapy, that was 15.1 months. And then when you compared it to encorafenib cetuximab alone, that was 19.5 months. And that arm was eventually closed early. So very, very impressive results, and as you can see here, it was in favor for all the subgroups that were evaluated, as you can tell based upon these floor plots. And then this year in February, as mentioned earlier, we were able to receive FDA approval for this indication for patients with newly diagnosed BRAF V600E metastatic colon cancer. And the response rate was very favorable. It's greater than 60%. The PFS was also greater than 12 months. At this year's ASCO GI, we also had another cohort, cohort 3, which had a FOLFIRI backbone. And I think that's really important because we want to provide options to our patients. There are those patients that may not be the best candidates for oxaliplatin-based therapy. They may have underlying neuropathy or other issues that they cannot receive oxaliplatin. And maybe they had adjuvant therapy earlier on when they were diagnosed with earlier disease. But here, this is looking at first-line FOLFIRI backbone, once again with encorafenib and cetuximab. A smaller study of 147 patients, that as you can see here, the control once again was standard chemotherapy with bevacizumab, plus or minus bevacizumab. Primary endpoint was overall response rate. And we noted once again a very favorable response rate of 64% versus the control arm of 39%. And what is very interesting, once again, is the FDA approval resulted in the approval not just of oxaliplatin-based therapy with encorafenib cetuximab, but basically 5-FU-based therapy. So it allows you to also utilize irinotecan. These were the toxicities that were noted for the combination with the FOLFIRI backbone. As you can see, there was some diarrhea, a little bit of nausea, anemia, and then neutrophil counts may have been decreased, as well as neutropenia, which I don't think is a big surprise to us. So there was a hint for a trend in improved overall survival based upon some of the preliminary data we had at ASCO GI. And at this year's ASCO, once again, Scott will be presenting our PFS and overall survival results at our oral presentation for colorectal carcinoma. So please attend that session if possible, abstract 3503, and that's on May 31st. Now there are some trials that are pending. One of them is CMARC. So once again, I had mentioned if you have an MSI high patient with the BRAF mutation, that's a hypermethylator. And this trial is a unique study. It's a phase 2 study, but it's taking into account not just providing those patients immunotherapy, but if you add encorafenib cetuximab to immunotherapy, will that make a larger difference in regards to PFS? This trial has completed enrollment. We do not have the overall outcomes as of yet. Now, what about the second-line setting, or the refractory setting? So there was data on dabrafenib, and trametinib, which is a MEK inhibitor, and spartalizumab, IO therapy, once again, the second-line setting for MSI stable BRAF V600E patients, and they reported a response rate of 25%. We also had data from the MD Anderson group with 26 patients enrolled, where they also looked at encorafenib cetuximab and nivolumab in that setting, and the response rate was 50%. And this really served as the platform for the SWOG study that was eventually created, which is SWOG 2107, where patients were randomized in a 2-to-1 fashion to encorafenib cetuximab with nivolumab based upon those promising results of the first 26 patients at MD Anderson versus encorafenib cetuximab alone. The primary endpoint was progression-free survival, and this was led by Van Morris at MD Anderson Cancer Center. This will also be presented right after Scott's presentation, actually, as an oral presentation by Van on May 31st. But here's some of the data that we have available based upon what is in the available online in regards to the abstract itself. The PFS was 5.8 months for the combination versus 6.3 months for the control, with a hazard ratio of 1.1. The response rate was 35% for the combination versus 32% for the control, and the overall survival was 13.5 months versus 11.6 months with a hazard ratio of 0.85. And you can see here basically the patient demographics. The majority of patients had one prior line of therapy, and the performance status was fairly equivalent between 0 and 1. So please go to those abstracts in regards to the oral presentation for colorectal carcinoma. Regarding basically novel agents available for RAS mutations, I think we're all looking forward to this. I don't think we need to discuss that this much further, but there's a lot of interest, obviously, in daraxonrasib, which is a pan-RAS inhibitor, and this basically was information from AACR, in which daraxonrasib monotherapy in first-line metastatic pancreatic carcinoma had a response rate of 47%. Small numbers, 38 patients, but obviously very, very intriguing. We all know it's going to be part of the plenary session regarding RASolute 302. What about in colorectal cancer? There's obviously some very interesting data for the pan-RAS inhibitors of 9%, and there's a lot of interest in obviously combining these agents as well. There's some concerns, obviously, regarding potential toxicities with some of the pan-RAS inhibitors, but then they also have focused drugs specifically for KRAS G12D, and obviously there's a lot of interest, and some already approved in KRAS G12C. Here's some of the preclinical data demonstrating if you focus on specifically the colorectal cancer patient population, you'll see that basically there is some activity for these agents, but in regards to the KRAS G12C, which is elanrasib, and for the G12D, which is zoldonrasib, it's best in combination with anti-EGFR therapy. And so we know for those drugs, they're best in combination. As you can guess, that's because there's adaptive resistance to the RAS mutation, so you can't give just the KRAS inhibitor alone in the setting for colorectal carcinoma. If you look at the Western blot, you'll notice that if you look at ERK and actin as your controls, and if you look at phosphorylated ERK, basically with time, once you hit the 24-hour mark, if you just provide KRAS inhibitor alone, there's still phosphorylation that returns. If you look at anti-EGFR therapy alone, the same holds true, but if you put it in combination, basically that's really where the benefit happens. So key questions: will pan-RAS or multi-RAS inhibitors combine safely? Will they increase response rate and PFS? And their likely potential limits of feasibility. I think this is actually one of the interesting diagrams we were talking about, which slides that we really like, and I like this little diagram here. In the presence of the RAS mutation, you really have a very cold immunosuppressed tumor, and in the presence of utilizing KRAS inhibitor, this basically provides a potential option to combine it with immunotherapy, because you basically get increased CD4 cells, increased CD8 cells, and creates a positive environment to consider for immunotherapy. So this is just a couple examples, combination with sotorasib and panitumumab, where 8 out of 10 patients exhibited increased lymphocyte clustering within the tumor microenvironment, really suggesting there may be a role for immunotherapy in this setting. So there is an ongoing trial, this is my last slide, that is being conducted at Mass Brigham, my understanding, and being led by Christine Parsigian and MD Anderson, where basically we're looking at adagrasib, cetuximab, and cemiplimab in combination. It's a small study, but it's going to be nice to see what those results are as well in this setting. And now I'm going to hand it over to Marwan.
Great.
Thank you so much for your attention.
All right. Okay, everybody. So my portion of this presentation, or this symposium, or whatever you want to call it, is really focusing on later lines of therapy. So we will be talking about, a little bit about targeted therapy, but more from a multi-tyrosine kinase perspective, and also what is the role of immunotherapy in MSS CRC. Touch base on some of the randomized clinical trials data that has been presented recently, and where the field may be going in the future as well. All right, so as a background, prior to 2023, we only had Lonsurf, trifluridine, tipiracil, and Stivarga, regorafenib. And those choices were based on randomized phase 3 clinical trials that had shown that trifluridine tipiracil versus best supportive care was superior, and the same thing applied to regorafenib. It was a modest improvement in overall survival, but nonetheless statistically significant, and one may argue by hazard ratio meaningful change for patients, but not really satisfying to many of us and to many patients based on the absolute magnitude and improvement. And for the longest time, the pattern of treatment following fluoropyrimidine, oxaliplatin, irinotecan, and anti-EGFR, if indicated, had been to really cycle between trifluridine tipiracil followed by regorafenib, or vice versa. And what we will be talking about today is how the field has evolved since then. So the Sunlight clinical trial has asked the question about what is the value of adding bevacizumab to trifluridine tipiracil in a third-line setting. And really the rationale behind that is based on the fact that there's been benefit beyond progression with targeting angiogenesis. We see that from going from first line to second line on the TML trial with bevacizumab. We see that with ramucirumab, and some data as well with aflibercept, all randomized phase 3 clinical trials in second-line setting. We also see that moving to a tyrosine kinase inhibitor in a third-line setting, namely regorafenib with a VEGF targeting component, is associated with improved overall survival. So why not adding bevacizumab to a systemic therapy in a third-line setting? Why wouldn't that improve the overall survival? And that was the rationale of this study. So this was a third-line clinical trial. These were patients who had progressed or were intolerant to fluoropyrimidine, irinotecan, oxaliplatin, and anti-VEGF or anti-EGFR therapy. Now, 3/4 of these patients ended up receiving VEGF, and about 1/4 of these patients did not. Patients should have had a known RAS status, and ECOG performance status here is 0 to 1. So that's very important to note that this study was for patients with good performance status. This was a 1-to-1 randomization, 490 patients, and the primary endpoint of this study is overall survival. Patients were stratified by region and also by a time of diagnosis of stage 4 disease until randomization and RAS status. So this study was positive, and the magnitude of improvement was clinically meaningful. You can see that with trifluridine. So again, this is not a randomized study to placebo. It's randomized to an active agent that improves overall survival. So the addition of bevacizumab to trifluridine improved the median overall survival from 7.5 months to 10.8 months. And the hazard ratio here was statistically significant, 39% prolongation in overall survival. And you can see that the median progression-free survival more than doubled with adding bevacizumab to trifluridine tipiracil. The hazard ratio here is 0.44, 56% prolongation in progression-free survival, which is clinically as well as statistically meaningful. So this led to the approval of trifluridine bevacizumab in the third-line setting. And here we proceed to the question. Which of the following best summarizes the efficacy findings from the phase 3 Sunlight trial evaluating trifluridine tipiracil plus bevacizumab versus trifluridine tipiracil alone in previously treated metastatic colorectal cancer? Adding bevacizumab improved overall survival and progression-free survival versus trifluridine tipiracil alone. Including bevacizumab improved response rates but did not improve OS versus trifluridine tipiracil. Adding bevacizumab demonstrated benefit only in patients with MSI, high disease. Trifluridine tipiracil resulted in superior disease control and fewer grade 3 adverse events than trifluridine tipiracil and bevacizumab. I'm not sure. Okay, so great. So I think the majority got it right here. Note the disease control rate was superior, obviously, with trifluridine bevacizumab than trifluridine. There were a little bit less adverse events on the trifluridine tipiracil, that's true, and there was a higher rate of neutropenia with trifluridine tipiracil bevacizumab, but that's largely related to the fact that those patients remained on treatment longer, and the longer you stay on trifluridine tipiracil, the higher the rate of neutropenia. Okay, so what we presented earlier was data on patients receiving trifluridine bev versus trifluridine in the setting of an ECOG 0 to 1. How do we really translate this data in our patients? Because we know that as we move towards third-line settings and beyond, we start seeing patients with ECOG performance status of 2. And some of these questions have not really been answered in the setting of prospective clinical trials, but sometimes this is where we turn to real-world data to try to understand some questions, understand some or answer some questions when we don't have prospective data. So this is real-world data that had been presented looking at patients who had ECOG 0 and 1, as well as patients with ECOG performance status of 2. And when you're looking at real-world data, it's really hard to tease out the progression, right? Because you really have good data from medical records or from billing purposes related to when you started the treatment and when you stopped the treatment. And you also have data as to when you switch to another therapy. So this particular study looked at time to treatment discontinuation. And the key message here from this study is that if you look at ECOG 0 to 1, it's a little bit longer, 3.6 months versus 3.3 months for ECOG 2. And if you look at the time to next treatment or death, there is really no substantial difference in these subgroups. Now, again, these are retrospective data. They're not really very very well vetted, but I think it does provide us comfort that for some patients with ECOG performance status of 2, you will derive some benefit from trifluridine and bevacizumab in that particular scenario. So how about patients who've had, a poor prognosis by different risk factors or heavy pretreatment, and how about patients who do respond well in terms of good progression-free survival receiving trifluridine bevacizumab? This is the BTAS trial that had been presented a couple of years ago with updates this ASCO, so everybody's welcome to look at those updates. But what you see here is an overall survival from real-world data, about 400 patients, of an 11.1 months, which is very similar to what we have seen on the Sunlight trial. The PFS is about 4.3 months, which is very similar to what we see in Bev pre-treated patients who received trifluridine and bevacizumab. One of the unique things that this study has looked at is trying to divide patients by prognosis based on number of organs involvement, based on liver metastases, and based on time of diagnosis until receiving a third-line therapy. All of these 3 factors being considered poor prognostic if you have 3 organs or more, liver metastases, or time to receiving third-line treatment within less than 18 months from initial diagnosis. And indeed, there was a prognostic impact as expected in the third-line setting, and you see that in the first and second-line setting. But I think one of the things that is unique about this study is that it shows that some patients do derive very protracted benefits from trifluridine bevacizumab. These are what they call the long-term responses, and it's not ORR, what they really term these, but really more like PFS of 6 months and longer. And so those were about 1/5 of the cohort, but within that patient subgroup that derives a PFS of 6 months and longer, you can see that median PFS of that subgroup is about 15 months, and the overall survival was substantial here at 23 months. And it basically tells you that there are some patients who have really a kind of protracted benefit from this combination. Unfortunately, there's really no good biomarker to identify those patients, however. Okay, so I think this data does convince us that trifluridine bevacizumab is a reasonable and actually a good option for our patients from a perspective of improving progression-free survival and overall survival. But what are the other options in patients in the third-line setting and beyond in patients with microsatellite stable colorectal cancer? So certainly we've got fruquintinib, which is a very potent VEGFR1, 2, and 3. And this potency is associated with improved activity as we compare to historic data, for example, from regorafenib, given the potency and selectivity of this agent. And obviously with that comes the risk of hypertension, but you get more potent anti-angiogenesis with using fruquintinib. And we know that the FRESCO-2 data has led to the approval of this agent, and that's a randomized phase 3 clinical trial. It's a 2-to-1 randomization, fruquintinib daily, 3 weeks on, 1 week off, versus placebo, and Kathy was one of the leaders on this study. This study looked at overall survival as the primary endpoint, with key secondary endpoints being PFS, ORR, DCR, and duration of response and quality of life. Note that this study really looked at patients who have not only received fluoropyrimidine, oxaliplatin, irinotecan, and progressed or were intolerant to such therapies, but these patients should have also received either trifluridine or regorafenib. And not only that, they could have also received both trifluridine and regorafenib. So this is really a fourth line, in a way, study and beyond, unless it's a patient who had FOLFOXIRI, Bev, for example, in a first line setting, and then got trifluridine, Bev in the second line. It would be a third line in that particular scenario. But those patients were heavily pretreated and had been exposed to all active or most of the active agents when they went on this study. So that's reflected by the overall survival of the best supportive care arm here. And you can see that the best supportive care arm had a median overall survival of 4.8 months, given the fact that this is pretty much a fourth line therapy and beyond. And there is a notable improvement here in overall survival. You can see that the hazard ratio is 0.662, which is an improvement of 34% prolongation in the overall survival, but the median is 7.4 months, so it's less than desirable for everyone, but it is a significant improvement. The progression-free survival, a notable improvement in hazard ratio, 0.321, meaning you delayed the progression here by 68% in these patients. And this was also a highly statistically significant p-value in this patient population. Note that the median PFS here is 3.7 months with fruquintinib, and placebo is 1.8 months. So this is a little bit better than what you would expect if you're using trifluridine alone, or if you were using regorafenib alone, again, with the limitations of cross-study comparisons. So this forest plot, in my opinion, is important because the FRESCO-2 looked at patients, as we said, who were exposed to all cytotoxics in 5-FU or capecitabine, oxaliplatin, irinotecan, and then plus. And that plus was either trifluridine or regorafenib or the combination. And what you see in this forest plot on the first row is patients who did not receive TAS-102 and Rigo, meaning they either received TAS-102, either received trifluridine, or received regorafenib. So really that 188 patients is pretty sum of the other of these two. And you can see that the median OS there is 9.3 months, placebo 6.6 months. So it's a little bit more than the overall population because they're not heavily pretreated. You can look at TAS-102, regorafenib. Again, regorafenib alone, 10.2 months. But the bottom line, the hazard ratio is what matters, and across the board, the hazard ratio is favorable here. So where is this moving as far as fruquintinib? I think fruquintinib is being evaluated, has been evaluated with IO agents. There are other studies combining it in earlier lines of treatment in combination with systemic chemotherapy. But in a refractory setting, there are also some IITs. And this is one example where fruquintinib is being evaluated with trifluridine tipiracil. So maybe thinking about this as a stronger anti-angiogenic agent than bevacizumab, and perhaps could you get a little bit more additive activity adding it to trifluridine than you would with bevacizumab. So that is an ongoing study. So this is now the algorithm. We've shown the data with sunlight. I think in practice, many are using the sunlight regimen, trifluridine, bevacizumab as a third line, and then proceeding to fruquintinib. There are some who use fruquintinib first and then move to trifluridine, bevacizumab, and I think that's acceptable and appropriate, and it depends on the discussion with patients and having goals of therapy and risks and benefits being vetted with your patients. Regorafenib, in my opinion, the space and the position of regorafenib is a little bit less clear to me at this point because really we don't have data on regorafenib post-fruquintinib. So even though fruquintinib has, for many of us, moved up ahead of regorafenib, some are still using regorafenib post-fruquintinib, but I think that's still a big question given some of the similarities in activity, at least from the VEGFR perspective, and what is the value of Rigo versus following fruquintinib remains somewhat unknown. So I would like to move to IO in microsatellite stable colorectal cancer in the refractory settings. And there's a lot of data here that we cannot cover because of time. So really the focus is going to be on more definitive phase 3 clinical trials that have shown improvement in overall survival. So we're going to be talking about the emerging data with zenzalintinib or Zenza. And Zenza is also a tyrosine kinase inhibitor, but what's different about Zenza is that it does target TAM kinases, and those are important in the tumor microenvironment and may actually preclinically have been associated with improvement in the tumor microenvironment that may make the responses to IO a little bit more favorable, especially in organs where responses are quite difficult, such as the liver. So the rationale to adding Zenza to immunotherapy really comes from a phase 1-2 study, the Stellar 001, which looked at Zenza alone versus Zenza plus atezolizumab. And what you can see on this graph is the median progression-free survival and overall survival. So on the first two plots on your left, it's the overall population, and you can see some mild improvement in PFS in favor of Zenza-atezo versus Zenza alone, 4 months versus 3 months. But what was interesting is when you look at patients without liver metastases, and then suddenly you see a big separation with Zenza plus atezolizumab having a median PFS of 8 months versus 3.3 months with Zenza alone. And there was some trend and improvement in hazard ratio as well in this particular scenario in favor of the combination. So based on such and this data, I think what we have seen is moving this to a randomized phase 3 trial. These are the AEs, by the way, on the Stellar 001, and I think the take-home message is that TKIs are not without toxicity, and one have to really be careful in monitoring these patients and make dose adjustments and interruptions as needed. And we've seen that with regorafenib, and I have to say this is a TKI that does require respect when you use it in basically making assessment and interruptions. GI toxicity, fatigue, asthenia are some of the most common elevations in LFTs, and you can also see proteinuria, hypertension in these patients, as well as bone marrow suppression. So with that background, Stellar 303 is a randomized phase 3 clinical trial that looked at patients who progressed on fluoropyrimidine, oxaliplatin, irinotecan with an anti-VEGF or not, and they should have had an anti-EGFR if RAS wild type, and BRAF inhibitor if BRAF V600E mutated. Those patients were randomized 1-to-1 to Zenza plus atezo versus regorafenib. Note that the rego dose here is a full dose of 160, and this is the overall survival. This was a statistically significant superior or positive study in favor of Zenza plus atezolizumab. Hazard ratio 0.8, 20% prolongation in overall survival. I think the difference is a little narrow, but it does continue to proceed up to the 2-year mark. As you can see, these curves continue to separate, and it is statistically significant. So 1.5 months difference in median overall survival, 10.9 months OS for the combination. Now, if we look at the stratification factors and different subgroups as well, you can see that irrespective of the geographic region, RAS status, liver or metastases or not, prior VEGF exposure or not, the hazard ratio is about 0.8 with an improvement in overall survival. So across the board, there's improvement. It's not a story of liver, non-liver in this situation. Now, AEs, yes, similar to what we've seen on the earlier trial, you will see a fair number of grade 3, grade 4 toxicities, as you can see on the slide, 56% grade 3 and 3% grade 4 toxicity with Zenza atezo versus regorafenib, a combination of 37%. However, the discontinuation rate is not different than regorafenib, 18% versus 15%. Patients do need dose modifications, and I think we have to learn how to modify this drug and dose it. There's no question. But I do think that there is statistically significant improvement in OS. So there are other studies trying to build up on this, and then this is a LAG-3 addition to Nivo plus Zenza, and it's an ongoing study. I want to spend a couple slides on other things that are happening, and I think the Zenza atezo is really a good example that there is a role for IO and MSS, but I think there's also the possibility that we're having additional agents that are moving into this field. This is the data from BOT/BAL, botensilimab, balstilimab. Botensilimab is an FC fragment enhanced CTLA-4 inhibitor. It has very strong activity in Treg depletion. And this is the Nature paper looking at heavily pretreated MSS-CRC. And what you see in purple on this slide in this waterfall plot is the patients without liver metastases. And you can see that the majority of those patients, the plot shows that the bar is going down. The overall response rate in non-liver mets was notable at about 20 to 23% in these patients, or 20 to 25%. No responses in liver mets, so liver is very resistant. And if you look at the phase 2 data, you can see that you do need a CTLA-4 to accelerate or accentuate your response. The PD-1 is also important because with monotherapy with botensilimab at a very high dose of 150, we do see 8% response rate. But at half of that dose plus a PD-1 inhibitor, balstilimab, you see that the response rate increased to 19%, and the toxicities were actually lower with the lower dose bot/bal than the single agent higher dose botensilimab. So certainly there is activity, and some of these patients was protracted activity. And this is one other slide I want to show on ADG126, because the field is moving towards trying to reduce the toxicities of the CTLA-4. ADG126 is a masked CTLA-4 antibody that has a modified epitope binding component of the antibody, and binds more strongly to CTLA-4, resulting in also stronger depletion of Tregs and activation and inhibition of CTLA-4. And if you look at the data on pembrolizumab, with pembrolizumab ADG126, at what is felt to be the recommended dose of 20 milligram per kilogram, the overall response rate in these MSS-CRC non-liver metastases was 31%, disease control rate 85%, median PFS 6.7 months, and there had been no discontinuation of the study. So there had been dose modifications, but patients were able to continue. So I think the field is moving, and there is hope for IO in MSS-CRC. There's no question in my mind. So with that, I will move to case number 3, a 68-year-old patient with metastatic colorectal cancer, transverse colon, T4A and 0, and this is a real story, but a different picture, of course. Subtotal colectomy in 2018 for his transverse colon. So the patient did receive Xelox at that time with significant difficulties. And a few years later, remember this was transverse, recurred in a peripancreatic mass. So this is probably a regional recurrence related to his T4 tumor in the transverse colon, with adenopathy and mass invading the pancreas. Along with that, the patient had retroperitoneal adenopathy, so this was not really an operable disease. The molecular testing revealed TP53 mutation, APC mutation. There's no RAS mutation, no BRAF mutation. HER2 negative, MSS, low TMB. The patient was treated with FOLFIRI plus bevacizumab for 9 months with a good response, but had significant GI intolerance requiring multiple dose reductions in irinotecan, and eventually elimination of irinotecan and subsequently dose reductions of 5-FU in combination with bevacizumab to maintain tolerance, but eventually had progression on 5-FU bevacizumab. So I turn this to both of you now, because the questions are multiple here. What treatment option would you consider next? Because this patient on paper has many options, right? But has also some,